see the speaker notes? Alina?
Welcome, everybody. Welcome to this first webinar of Social Service Workforce Week. My name is Hugh Salmon, Director of the Global Social Service Workforce Alliance. Let's just wait 1 or 2 minutes for other people to arrive. So just to welcome you again, if others are still just arriving now, this is the first webinar of Social Service Workforce Week, hosted by the Global Social Service Workforce Alliance. My name is Hugh Salmon. I'm the Director of the Alliance based in London. I'm sure you're joining from all around the world. We have about 220 registered attendants, so we are sure that there'll be a wide range of people. So you're very welcome to join us for our webinar today. And we have another webinar coming up tomorrow as well, which I'll mention briefly at the end. I'll just ask my colleague Alina just to confirm if we feel we have enough participants to get going.
Sorry, yes, I would go ahead.
Okay, thank you so much, Alina. So if we go to the next slide, please. This webinar is on the role of the social service workforce in health facilities, but specifically in addressing the social determinants of health, because we recognize, and we have certainly recognized through our research for this paper, which you can now see on the screen. This is a just released paper on the role of the social service workforce in health facilities, specifically looking at their role in addressing social and other determinants of health. So the way in which social factors and emotional behavioral factors in their environment can impact on their health, on health treatment outcomes, and trying to achieve more holistic solutions to both health and social problems. So by all means, please go on our website and you can find the link there under our resources. You will see resources, Alliance resources. You can see this paper and explore it at your leisure after our webinar today. And if we go to the next slide, I can run through the agenda and introduce you to the main people that we have speaking. So after myself, we're delighted to have Han Kang, who's the director of the Office of HIV/AIDS based in Washington, DC, and that's in the Bureau for Global Health in USAID. So Anne will give a few opening remarks. And then we'll go over to Alex Collins, who has been a consultant for the Global Social Service Workforce Alliance and is a senior technical advisor on child protection with Palladium, also based in the US. And Alex, who's the lead author of the paper, will be talking about the types and roles of social service workers in health facilities, the different models for their deployment, and the issues around the related health outcomes that we have seen as a result of deploying social service workers in those different health facilities. Then moving on, we'll be hearing from Richard Savo, who is the former Deputy Chief of Party for Pathways, which is a project for orphans and vulnerable children in Zimbabwe, and he is with the Catholic Relief Services in Zimbabwe. And he'll be talking about, he'll be giving us a spotlight on some examples from Zimbabwe of types, roles, and functions and health outcomes related to social service workers, specifically in health facilities, using those examples. Then we'll hear from Alex again about models of training, management, and supervision, and the different costs involved, as well as the cost savings that can be seen as a result of more effective treatment and improved outcomes from combining health with social service workforce. And then we have Dr. Bernadette Madrid from the Philippines, who's the director of the Child Protection Unit of the University of the Philippines and of the Child Protection Network in Manila. And that's in the Philippine General Hospital. And she's also Associate Clinical Professor of Pediatrics and Executive Director. And so we'll be talking about Dr. Bernadette will be speaking about the interprofessional training and team model that they use there in the Philippines. And that will be more of just an additional example and some questions that you might have for Dr. Bernadette. And then Venera, who is the other consultant who worked very closely with Alex on the paper, based in Kyrgyzstan. Venera Urbaeva will be speaking about a summary really of the opportunities, challenges, and recommendations arising from the paper. Then we have a little chance for some Q&A, and Venera will be curating that Q&A, and I will give some closing remarks. Just a few points on logistics. So obviously we urge you to submit any questions that you have through the Q&A function. Hopefully you can see that at the bottom of your screen. If you put a question in there, it's much easier for us to manage it and for us to pass it on to the relevant person. If you have any technical difficulties or you can't hear or you can't access something during the meeting, then you can send a message to the host through the chat button. Just select host and then put in your chat, and then Alina or someone else will respond to you. And just to note that this webinar is being recorded and it will be made available via the Alliance website. So if you can't stay for the whole thing, or if you have colleagues who want to listen later, then the recording will be available through our website. Okay, I think that's everything from me for now. I'm delighted to hand over to Han Kang, who's the director of the Office of HIV/AIDS in the Bureau for Global Health in USAID. Over to you, Han. Thank you.
Thank you very much, Hugh. First of all, good morning, good afternoon, and good evening to all of you. As Hugh mentioned, my name is Han Kang, and I currently serve as the director for the Office of HIV and AIDS in the Bureau for Global Health at USAID in Washington. Now, I joined the agency 15 years ago, and I've served in Ethiopia, Myanmar, Nepal, Nigeria, Pakistan, South Sudan, and Zambia, where my colleagues and I have supported the development and expansion of social service workers, really through partnerships in HIV and AIDS, through PEPFAR, and also through our maternal and child survival programs. Now that I've returned to Washington, I would say that the best part of my role is really the opportunity to work with colleagues like Annalise Lam and Colette Peck and Tiwana Jones, who are with us here today, and also Maury Mendahal as the senior advisor, who's also trained as a social worker. Now, I'm delighted to join all of you in this event during Social Service Workforce Week. So to all of you who are social workers, those of you who support them, and those of you who are studying social work in this event and around the world, we see you, we salute you, and we thank you for your devotion, your efforts, and your life-saving impact. Now, I began before USAID as an HIV testing counselor in a community clinic serving primarily immigrant and refugee youth, many of whom were rejected by their families and kicked out of their homes. What I loved about that setting was that we could offer them more than just a test, more than just a medicine. We could offer them, through the social workers who were actually linked working in the clinic, we could offer them opportunities to live, to study, and to work. Really, these are opportunities to be who they were born to be. It really was the social service workers trained as case managers who made these connections and ultimately chip away the discrimination, the inequity, and the injustice that can really increase anyone's risk for HIV. So here at USAID, we certainly share an interest with all of you to formalize, grow, and protect the social service workforce in our partner countries, as articulated in the report that will be discussed today. While our investments in the social service workforce have roots in serving children who have been orphaned and made vulnerable by HIV/AIDS and other challenges, let's also recognize and advocate for the formalization of cadres who serve key and other priority populations. Social service workers also deserve the same kind of attention, protection, and safety associated with health workers. So for example, what we would recommend to the World Health Organization is to expand the scope of its surveillance system for attacks on healthcare to include social service workers. Social service workers, as we all know, have life-saving and essential roles. Therefore, we all have a collective responsibility to ensure the depoliticization, impartiality, independence, and neutrality of social service workers, similar to their counterparts who deliver humanitarian assistance. So I look forward to working with you, engaging with you, learning with you on all of these efforts, and certainly look forward to hearing from other colleagues who are with us here today in this event. So Hugh, back to you.
Thank you very much. Sorry for the slight delay there. Yes, thank you so much for those opening remarks. I'd now like to hand over to Alex Collins, who's been the consultant and is the lead author of the paper that we're going to be hearing about today. Alex, over to you to bring out some highlights from the paper. Thank you.
Thank you so much, Hugh, and to Han. I think it's thrilling for me to be here today with the support of USAID and the Alliance to really skim the surface of some of the findings that we pulled together in this report. And as you mentioned, Han, the unique contributions that social service workers make in the health sector and the disparate recognition they have in what those contributions are toward contributing toward patients' improved health outcomes. And so now I'd like to take us through a few highlights. And as Hugh mentioned, I'll walk us through some of the types of social service workers that we found through the literature and through key informant interviews that were most commonly found either linked to or engaged by health facilities. We'll really try and spend most of our time in the two spotlight sections that Hugh mentioned as well with Dr. Madrid and with Mr. Savo coming in from Zimbabwe and the Philippines. So in terms of types of social service workers in health facilities, we really found two scenarios not tied to socioeconomic development status, but really influencing the reliance of health sectors on these types of workers to address those non-medical factors that can be so influential in health outcomes and in the ultimate costs of care. In settings where social work, which is one of the primary disciplines that we see within the social service workforce, where it was fairly new or still really in the early stages of professionalization. And by that, I mean a little legislation in place recognizing formally social work as a profession or setting minimum qualifications or standards in terms of a professional association in place or really rigorous training programs or expectation of holding a diploma or degree. It seemed like for health settings that needed to be or wanted to be addressing social and other determinants of health, that they were turning toward use of paraprofessionals or community volunteers. We'll see that in more detail in the spotlight from Mr. Savo, as well as repurposing existing health worker cadres and giving an extra layer of social services orientated training, such as to say a nurse visiting program that was really not just to follow up on health status of say a young mother and newborn, but to be assessing housing, income, those other social and other determinants of health to address the overall situation and ensure better outcomes for mother and child. Just one example there. The second scenario that we saw was where social work was more established as a profession, so had that legislation in place, the normative framework, a professional association or union council that was regulating the profession and setting requirements for minimum qualifications. And in those cases, the types of workers that were relied upon to play these social service oriented roles in health facilities were typically assigned full-time to a specific facility in pairs or in a solo duty station, or were even integrated into healthcare teams, typically with a doctor, sometimes with a psychologist, with a member of the police force, lawyers, who could address as an interprofessional team all of the different factors involved in a patient's case. And so if we move on to the next slide, those types of workers could be deployed in 3 different ways. We saw them deployed in a roving or liaison model where a social service worker would be that key link between a facility and community or cluster of communities in the catchment area, where they would be permanent and on-site support, such as a social worker assigned to a specific facility or a child and youth care worker assigned to be supporting a specific facility or point of contact, as we'll see with the Pathways Project. And then an interprofessional team model where the social service worker either leads or is a key member of a team of professionals and paraprofessionals who bring different disciplines to bear on a patient's care. So if we go to the next slide, there were some health outcomes that were specifically cited in the literature and then reinforced in the key informant interviews as linked or corresponding with some of these models. And I'll highlight only a few. In terms of to this liaison or this clinic community linkage model, in some of the literature, there was more use of contraception and fewer births among adolescent mothers who were receiving community outreach from a worker who had this specific social service, either background or training. With the permanent on-site support model, there was reporting by patients of having better access to resources, drawing on that knowledge that a social service worker brings of the available community resources and facilitation of referrals and case management. And then they also reported lower psychological distress. And this was among patients with complex needs who often benefit the most and from a social and health integrated model. And then finally, with the interprofessional team model, some of the literature pointed to either with a social service worker leading the team or as part of the team, that patients had fewer symptoms of depression and anxiety when they were associated with that type of care, and also more appropriate and less costly care access. So they'd be going to their primary care provider rather than seeking out urgent care, emergency room care, and we're less likely to be admitted to hospital or have a shorter length of stay. So all this we think is, if we move to the next slide on roles and functions, we saw attributed to 4 key roles that social service workers can play in health facilities and that they seem uniquely prepared to play compared to their health worker counterparts. That of a behavioral or mental health specialist, for which a doctor or nurse does not typically have the same type of training or the time within their cases for the day to provide that kind of assessment and either specific counseling or referral for more intensive care. That of a care manager, social service workers drawing often on their background in case management and able to manage not only the care and navigation of the system for the patient, but also manage the expectations of the care team and educate them in terms of how it's not just addressing the medical issue that will make the greater impact, but also seeking out how to ensure a stable environment for a patient when they're discharged, or address other factors influencing their health outcomes so that they're more adherent to treatment or more likely to seek care. So the most frequently noted tasks or functions in the literature were grouped into these roles. And you'll see on the next slide how they were grouped, and you can get a lot more detail in the report itself. But what you can see here as well is certain tasks falling across multiple roles, such as applying standardized assessment tools, facilitating communication, relationship building and advocacy among patients, providers, and services across a range of sectors. And these tasks seem to draw specifically on key social work competencies. And with that, I'll transition into our first spotlight and ask Mr. Richard Savo to turn on his mic and video so we can ask a few questions and learn more about use of the point of contact cadre in Zimbabwe. So to kick off, thank you so much for joining us, Mr. Savo. Could you speak please to the types of social service workers that you've been involved with in your role with Pathways in health facilities?
Yes, thank you so much for that question. And maybe let me just give a brief context to the Pathways project so that we can then be able to situate this social service workforce within the project. So the Pathways project, funded by PEPFAR through USAID, was being implemented by Catholic Relief Services and its partners in 10 districts of Zimbabwe. And the major focus of the project was to enhance the resilience of orphans and vulnerable children, their families and communities. And in all this, trying to support them to achieve positive health and social protection outcomes. And at the center of the intervention was the livelihood of the orphans and vulnerable children, especially affected or infected by HIV. So in short, this was a community-based approach to achieving HIV epidemic control. Then coming to the types of social services workforce that were interacting with the health facilities, we basically had 3 categories of social service workforce with varying degrees of interaction with the health facilities. So at the higher level, we had professionals, and these are our social workers and other social scientists who were in charge of the entire HIV-sensitive case management process, the coordination, and working with multi-sectoral partners. Then below this broader social workers, we then had a cadre that we termed point of contact. And this point of contact was stationed within the health facilities and was there for the whole week working with the health facilities. And this is a paraprofessional who was stationed within the health facility to act as a liaison or a link for the clients between the community and the health facility. So in other words, the point of contact was an extension of the OVC program and playing this key facilitatory and intermediary role for our clients. And then the third category, who also had some degree of interaction with the health facility, are the community-based cadres or volunteers who are responsible for the direct service provision, and this could be childcare workers, this could be cognitive behavioral therapists, this could be positive parenting specialists. So in a nutshell, these are the 3 categories of social service workforce. But I know today we will then spotlight mainly on the point of contact who had direct impact or interaction with the health facilities. Thank you.
Thank you so much. So we'd love to hear more about the specific role that the point of care contact or point of contact cadre played compared to others, and specifically how you saw them making a difference, be it positive or negative, in patients' health and well-being and that of their families and communities. Over to you.
Sure, thank you so much. So the point of contact, I must say they played a dual role. a dual role in the sense that they could provide direct health-related services, but also, and more importantly, there would be a linkage to the broader wraparound social protection interventions, especially applying the socio-ecological model. And key among their role is also to bring the case management approach to the health system. And that way, they will be complementing the differentiated service delivery model that is often used within the health system. So they were very central in terms of bringing that scientific and systematic process of case management within the health setting. And through that systematic work that they're doing, we then also saw their role and influence around HIV prevention and response, especially facilitating diagnosis of HIV infections, also facilitating HIV testing and index case tracking for the clients that they were also working with. In terms of even direct service provision, these are cadres who were trained in terms of providing adherence counseling, in terms of providing HIV treatment literacy, HIV disclosure support, and even facilitating and supporting viral load tracking. So in that way, they also became very key players in ensuring uninterrupted service delivery for our clients and ensuring that clients were retained in care through collaborating with health facilities and tracking all those clients who may have defaulted from their treatment or who may have missed their appointments. So they then played that key intermediary role. So in terms of the other role, in terms of also addressing the social determinants of health, the point of contact would then either link or provide wraparound social protection interventions that have an implication as well, the achievement of positive health outcomes. For example, health outcomes would be determined by a stable psychological or psychosocial state of affairs within a client. So it became their role to link these clients with psychosocial support and other mental health interventions that could be found within the communities. They also linked clients with education support. They also linked the clients with economic strengthening interventions, because this way the household was also supposed to then play a key role in supporting the health outcome of the children. Then they also, some of the wraparound services also include positive parenting sessions, disability-specific services, and also being key players in case conferences, especially when it came to some complicated cases or where children or clients may have been struggling to adhere to their medication. So these are some of the roles that the social service workforce or the point of contact have been playing within the health facilities.
Thank you so much. And we are only having a brief moment for this spotlight, so I'd encourage everyone joining us today to put further questions for Richard in the question and answer window, and we'll hopefully have time for more conversation during that section. So if we'll move forward to a few more highlights from the paper before we speak to Dr. Madrid on the interprofessional training model and team model. Next slide, please. In terms of models for training, next slide, please. What we saw in the literature, and that was supported by those we spoke to, was that there are certain core competencies that social service workers, be they professional social workers or paraprofessionals, child and youth care workers, really what was most important was that they were leaders in terms of collaboration and teamwork, cultural humility, reflection, advocacy, their partnership skills, interpersonal communication, and empathy. And what you'll see here visualized in this figure from OPM is that there's a fair amount of overlap when you look at the qualifications and competencies across the social service workforce. and the allied workforce and other sectors. And I think that lends itself to the flexible options that in some cases, and as we alluded to in the two different scenarios to start the presentation, where social work or other formal disciplines within the social service workforce are emerging or in that process of professionalization, that there is an opportunity to draw from existing health cadres to achieve some of the work that we saw linked to improved health outcomes when you were addressing more holistically a patient's needs and not just focused on the presenting medical issue. And what a big need coming out of the literature was that if you do have a multitude of professions or training backgrounds coming into serving in these roles, that there truly needed to be systematic assessment of whether students have the knowledge and skills to have these integrated practice competencies. Next slide, please. And another key piece coming out of training was that bringing different disciplines together for their actual training before they were working together as a team of multiple disciplines in their workplace was really important, not just to their overall ability to practice integrated care later on, but to demonstrate the value of the social service workforce within the healthcare team, that doctors in training alongside social workers in training, being on the same home visit and seeing how the social service work student was engaging with the family, was doing, applying that social ecological model, doing a biopsychosocial assessment was really important for them later to, in their team, seeing that value. And that's one of the main challenges in terms of social service workers gaining their footing and having that true contribution and practicing to the top of their scope, is that appreciation and recognition of what they bring to the team and to the health facility. If we move on to the next slide, we were able to distill 4 options for management and supervision, since when you have a social service worker coming into a health facility, there can be various streams of authority or hiring entities between, say, the social services ministry or department and the health ministry in terms of who is recruiting, who is paying, who is managing and supervising. And I'd encourage everyone to do a deep read of the report, since we are able to pull these 4 options out and talk through the various advantages and disadvantages to each and how they might work in a specific context. And then finally, I'd like to highlight some of the associated cost savings that we saw evidence for in the literature when you have any of these models in place, say the roving liaison model, doing that community clinic linking. There was evidence that there was reduced admission into costly or more intensive forms of care, like the neonatal intensive care unit, and a 2-to-1 return on investment for any of that investment in the multidisciplinary care management intervention. In a review of different models of integrated health and social care focused on primarily low-income populations, when you had a care coordination and community outreach intervention that had that social service worker engaged in the health facility or health team, that there were decreased visits, admissions, and lengths of stay in hospital. And then finally, care coordination where the interprofessional team model was employed within primary care, and then within emergency room, there were reductions in emergency room visits, and also a more efficient use of resources where patients presenting in emergency rooms where a social worker was based. In this last bullet, only 16% ended up being admitted to hospital, since the social worker was able to refer to more appropriate services based on the overall situation of the patient. Since medical care can be one aspect that's needed, but may not be the most impactful issue to target first. So I'll switch over to our second spotlight with Dr. Bernadette Madrid. So if you could please turn your video and mic on. And we will work through a few questions with you about the Women and Child Protection Unit model in the Philippines, specifically bringing different disciplines together. So Dr. Madrid, over to you. If you could share some of the thinking behind bringing these different disciplines together in the units, and whether there was any initial resistance to setting them up and how that was worked through. Over to you.
Yes, thank you, Alex. When we looked at the needs of the survivors of violence, both women and children, we found that there is no single sector or discipline that could provide all their needs, and that the very foundation of their needs were centered around medical, psychological, social, and legal services, and that if all of these services were scattered, were not in one place, they fall through the cracks, So we felt that if we could put all of these professionals together, working together in one unit, that we would provide better service and that we would achieve our outcomes effectively. So we wanted abuse to stop. We wanted the child to remain in school. We want any medical or psychological problems to be managed, and also for the family and the child to be linked to resources in the community. So basically, we felt we needed a physician, a social worker, a police officer, and a mental health service provider, all working together in one unit. And I think, in the beginning, that's why we chose the healthcare delivery system, because in the Philippines, 3 of the 4 is already in the hospital. The physician, the social worker, the medical social worker, and the mental health provider are already in the hospital. And we just needed to add on the legal service. So it made sense. And the hospital, we felt, was a natural gateway to access services, whether the survivor disclosed the abuse or not. And well, one of the challenges was to really persuade the Department of Health that violence is not just a social welfare problem, that violence is also a health problem. And I think our research in adverse childhood experiences and how that results and the consequences of those years down the road was one of the key factors in persuading our health sector that this is also a health problem and that we have to work with the social welfare and the legal sector for us to be able to really provide the necessary services for our survivors' violence.
Thank you so much, Dr. Madrid. In terms of how the training is handled of bringing together the different disciplines and how you've seen that training affect the workers in their interactions together and contributing to patient care. Could you speak to that, please?
Yes, there are discipline-specific trainings, but we find that with these teams that we're establishing, the women and children protection teams, that they have to be trained together. In fact, it's one of our requirements. You cannot establish a women and children protection unit if the team has not undergone training together, because we find that their relationship with each other and understanding each other's roles, responsibilities, and limitations also was very important in making the team work effectively. And this can only be achieved if they train together. You just don't put them, you just don't put them together like that and say, okay, now you are a team. It just doesn't happen that way. They have to be trained together.
And what have been some of the most important results that you'd like to highlight for having this interprofessional training and implementation model in place in the WCPU?
Yes, we did an evaluation and we followed up our patients 5 to 10 years after first consultation. And we find that our re-abuse or our re-victimization rate was quite low, 6.5%. And in terms of their trauma symptoms, it was also lower compared to when they first consulted. So suicide attempts and self-harm were also low, less than 10% compared to 28% when they first consulted. And the children who were now adults also felt that they were well supported through the legal system, and the prosecution rate was also higher. So I think we were able to achieve those objectives that we wanted for this, why we needed this team to be working together.
Thank you so much, Dr. Madrid. And again, for those joining us today, please put any further questions you have on this compelling spotlight into the chat or the Q&A window. And we hope to have time for a few during that section of the presentation. At this point, I'll invite Vinita to speak at a high level to the opportunities, challenges, and recommendations coming out of the report. Thank you. Over to you.
Thank you, Alex. Thank you so much. Alina, can we go to the next slide, please? Yeah. So social service workers encounter various challenges when performing their day-to-day responsibilities. As you can see from this figure, one of these challenges is unclear job expectation from their health colleagues. Often there is little awareness and understanding of the unique role of social workers in healthcare settings, which may also lead to social workers performing functions that do not fit their professional competency. In some countries, our research has shown that there is little appreciation for biopsychosocial approaches in addressing health conditions, and thus social worker contributions and their role is actually not recognized, diminishing their efficacy and integration into the healthcare system. We can also see that poor awareness and recognition have disadvantaged health social workers, putting them at the bottom of the hierarchy, especially in authoritarian settings. Such power differentials also affect ethical decision-making processes, which leave social workers professionally isolated and unable to fully contribute and partake to support their clients. Among other challenges is insufficient pre- and in-service training and absence of supportive mentorship and guided supervision, which also, of course, add on to the problem of professional isolation for social workers. However, we'd like to highlight the opportunities that exist at each level, despite these challenges that can be tapped to support health social workers. We can see that at the individual level, this may include training on coping skills to address burnout, clarifying and articulating the roles of social workers through various provisions, mentorship and guided supervision. We can also see other opportunities in terms of making changes, physical changes, which include providing separate rooms for counseling and designating specific resources for transportation, so the social workers can conduct home visits or follow up for discharged patients. And as it has already been highlighted by the earlier panelists, interprofessional training and education can strengthen collaboration and increase trust and mutual understanding of the role of social workers. And this is really a great point of entry for various kinds of programs. At the policy level, we see opportunities in terms of increasing resources for salaries and our other costs, as well as regulatory framework for professionalization of social work and other cadres. Can we go to the next slide, please? So the following recommendations are organized along 3 dimensions for strengthening social service workforce in healthcare settings. This is not by any means an exhaustive list, but just some priority considerations for policymakers and other people working to support and strengthen social service workers in healthcare settings. It starts with the planning stage, which includes interministerial leadership and coordination to deploy social workers in health settings. Here we're talking about a paradigm shift from the traditional health care workforce to broader workforce for health, which includes and recognizes social workers as critical members of healthcare systems who are working alongside with health professionals to promote population health. The planning process should also encompass creation of appropriate formal structures and job descriptions for social workers, articulating the role of social workers in an interprofessional teams, which is really fundamental for effective cooperation and coordination of their work. It's not just for the medical doctors, but also for the social workers to be able to clearly articulate and communicate their professional and their specific role in that context. And if we go to the next slide, this can be further reinforced through interprofessional learning. As we have already heard from the Spotlight talk, we were able to witness that there are a lot of opportunities in terms of interprofessional learning, which can be done, which not only contributes to addressing, the role clarity and mutual cooperation, but it also validates and integrates the scope of practice of social workers within those teams and also fosters effective collaboration. These efforts can also be advanced through development of competency frameworks for social service workers in healthcare settings and adoption of standards related to integrated care, which can, in the end, create an enabling environment for social workers to apply their specialized knowledge and skills. Can we go to the next slide, please? And this brings us to supporting the performance and recognition of social service workforce in health facilities. Social workers in healthcare settings need regular and supportive supervision and mentorship, including peer-to-peer supervision. And this can be done in the form of individual or group supervision, which can be an effective means of ensuring support, promoting reflective practice, learning, and professional development. Peer-to-peer supervision can enhance their connectedness to other social workers and build their capacity to address complex patient needs. Professional recognition through appropriate regulatory framework is essential in order to establish the legitimacy of social work as a health-related discipline. This refers to cultivating a sense of awareness and credibility as to the role of social workers in the healthcare system. And just to sum up, our research has demonstrated that social workers in healthcare settings can make a significant contribution to health equity and to advancing the right of people, of all people, to the highest attainable standard of health. And they do this through greater focus on prevention and health promotion by addressing the non-medical factors that account for over 50% of health outcomes. So we can see there are multiple benefits to strengthen social service workforce in healthcare settings. And now I would like to invite you to ask your questions or perhaps make comments to the panelists and the speakers that we had today.
Hi, everybody. Hi, Vanita. I was just looking at the questions that we have in Q&A. I can see that there is one specifically addressed at Dr. Bernadette on the Philippines. And there was also a couple of comments. I'm not sure, maybe another volunteer could maybe Bernadette, could you give a verbal answer to the question? Can you see that one?
In the Philippines, yes.
Yeah.
In the Philippines, if the similar model is being applied at the PhD level, how do the social workers' role and scope relate with barangay health workers, which is community health workers?
Yes. I remember that my work is child protection. So we also have actually within the community violence against women and children desks in the barangay. So the social workers work more with them when it comes to intervention rather than the barangay health workers. Barangay is the smallest political unit in the Philippines. It's like a village. But now, with the Philippines transitioning to universal healthcare, we are looking into how women and children protection can be integrated into the universal healthcare. And here, we will probably have a bigger role for the barangay health workers, especially for prevention programs like parenting and some of the home visits, for example, can be done by the barangay health workers. So I think that in the future, we will be working more with them also, and not just the violence against women and children desk officers.
Mm-hmm. Thank you so much, Dr. Madrid. There is another question from Doriska. I just hear speakers refer to social workers. In our country, the social workers have a pathology approach to serving clients, whereas child and youth care workers work within the life space of the clients. Do you include child and youth care workers in your workspace? So Richard, would you like to address, and maybe Alex?
Yes, sure. We do have a wide range of social service workforce, with social workers, with counselors, with youth workers, and everyone coming in to check their portfolio. But maybe I can also even respond to the issue around coordination. How did we coordinate? So we then had to come up with a technical working group, which was a multi-sectoral technical working group with social services workforce, clinical workforce, health service providers, and we would come together to plan on how we were to provide service. And one key outcome that was outstanding for us was when we started, out of our 10,000 children living with HIV, we had less than 40% of them with a valid viral load result. But through that coordination and complementarity, we managed to move that from the 40% to above 80%. So, which was a key lesson that we also wish that it could then continue to provide those positive outcomes. So it's around coordination and collaboration.
Alex, would you like to add to that? Yeah, thank you.
Yes, related to the question on planning and coordination that Richard just responded to, I think another thing that this paper did, and I'd urge folks who are interested in that aspect to look into that section of the paper, is take really initial steps toward what models are out there for estimating the cost savings, or in some cases, cost efficiencies of involving a social service worker, be it a formal social worker, be it a point of contact type cadre or roving or liaison type model, and how to start making that case within the existing planning and coordination mechanisms for workforce with those costed arguments, showing how limited resources could be invested to support the role of a social service worker within a health facility, within any of those three models, and how it's not necessarily an added cost, but can save and allow for more holistic care at the same time. And in relation to the question from Dorsika around child and youth care workers, we actually spoke, one of our key informants came from the NACCW in South Africa, and we wanted to make sure we were not only focused on social work as a discipline, since it is an inclusive definition from the Alliance of who makes up the social service workforce. And I think it's really compelling to see the latest Impilo model going on in South Africa related to involving child and youth care workers specifically in health settings and in involvement with families in their life space, but also addressing specific health issues and being in that community engagement referral role as well. And so I would urge you to look at what we were able to pull out of the Impilo model and spotlight in the paper itself it was a good example of what to look for and what to avoid in terms of that specific administrative or technical supervision of social service workers who might be brought on board by the health sector and need a different type of supervision to do their role well. Back to you, Vanita.
Thank you, Alex. There is another really good question on M&E framework. How can we have an M&E, a monitoring and evaluation framework to measure the contribution of social workers in health settings? Are there any guidelines on this, or maybe tools? Yeah. Alex or Dr. Madrid, yeah.
Sure, I'll just go ahead, Dr. Madrid.
Yes, I'm not sure if I think the tool might be available in our website, childprotectionnetwork.org, because it's how we monitor the different WCPUs. So the monitoring is not just specifically on the social workers, but really it's more like the function of the whole team. But of course, for the supervision of the social worker as a member of the team, there is a separate monitoring by the supervisor for the social workers under her mentorship. So yes, certainly needed, and it's something that we want to strengthen, because right now it's, like theoretically it's there, but it still needs a lot of work.
Alex, do you have anything to add?
I would add just briefly, one of the overarching needs coming out of the research was a greater focus on supporting those links between the contributions of social service workers within health settings and to improved health outcomes, to other outcomes beyond health, say the household's overall economic stability, whether they have secure housing, nutrition, et cetera. And so there were a few really good exemplar papers around making those connections and doing bigger evidence reviews, but definitely a need for more. And I think this community on the line today is poised to be able to contribute to filling that gap.
Thank you, Alex. And we can share the link to the website that you have mentioned, Dr. Madrid, in the follow-up emails. And I think we're a little bit out of time. So with this, I would like to thank the speakers and the panelists and give the floor to Hugh.
Thank you so much, Vanita, and thank you everybody for your wonderful contributions today. I'm so sorry that we haven't been able to cover everybody's remarks, everybody's questions so far, but it was great to have at the outset, the warm welcome from our USAID colleague Han, talking about just the importance of the workforce and the crucial roles that they play and the need for greater recognition and protection of their roles. So it was excellent to have that opening message. We then heard from the authors of the paper, from Alex and Vanita, who talked a little bit more about some of the findings in the paper, some of the issues that they explored, and a number of different models there are discussed in some depth in the paper, with a lot of evidence from the key informants and from the literature that we reviewed. So I encourage you, please, to have a look at the paper, which you can see, again, is available on our website. And also we heard from Richard and from Bernadette, and they gave some very specific insights from the Zimbabwean context, from the Philippine context, and also specifically how professionals work together collaboratively. And that's really encouraging to see, both in a hospital setting, but also in community settings. So I think that this webinar has provided endorsement of some of the key findings in the paper, but also showed that there's so much more that we could do to understand these issues more deeply, and there's so much more discussion that we could have. So I just urge you to continue to engage with us through the other events that we have going forward. We have a webinar tomorrow on the issue of ratios and costing. Some of you were asking questions. I think Sunday was asking a question about ratios. So we're talking about the importance of setting a target ratio or a minimum ratio for numbers of social service workforce to population. We'll be discussing how to do that tomorrow. And we'll also be looking at how you cost the workforce, because obviously often there is just a gross underinvestment in the workforce. And the only way to get proper investment is to have really clear costing. And so people know how much it would cost to achieve the ratio that has been set as a target for growing the workforce. So very much encourage you to join again at the same time tomorrow for that webinar. And please continue to follow us through our website and on social media. And you're welcome to send in additional comments and questions that you have through our contact email address, which you'll find on the website, but also through social media, so that we can continue this conversation and hopefully continue to improve this guidance as we go further forward. So without any further ado, I think I should bring this webinar to an end, but thank you so much for joining, for participating, for all the speakers and panelists. Please bear in mind that the recording will be available for others to access later. Apologies that we did not have any written or oral translation on this occasion, but we're certainly working in the next year to have more and more of these resources available in other languages. And if possible, we'll try and get this paper translated as well. But if you have a specific language request, let us know, and we'll see if we can meet that need, if at all possible. Thanks again. Thanks for being with us today, and goodbye.